Ladies and gentlemen, good day. I'm Michael Wang from MD Anderson. I'm a Putin Clark Endowed Professor in the Lymphoma and Myeloma Department. Today, it is my great pleasure to present to you the BTK inhibitors on mantle cell lymphoma therapy. BTK inhibitors have revolutionized the therapy for B-cell lymphoma, and especially for mantle cell lymphoma. We have 3 generations of BTK inhibitors now, with each generation being approved by FDA for relapsed mantle cell lymphoma. The first one, as we all know, ibrutinib. Second one, Acalabrutinib and zanubrutinib. And there's new ones coming called relapsed is in trial. So all these first and second generation inhibitors are covalently binding to BTK protein and therefore irreversible in their inhibition. The difference between the first generation and the second generation is that the second generation might be of similar efficacy, but they have reduced the toxicity. So these two, Acalabrutinib, zanubrutinib, are considered less toxic than ibrutinib. The third generation is different from the first 2 generations. A major difference is that the third generation is non-covalent, therefore their inhibition is reversible. And so that's represented by Loxol 305, what we call it. Now the name is pirtobrutinib. I will use brutinib thereafter. This has been approved in January of this year, 2023, for relapsed mantle cell lymphoma by FDA. So the other 2, especially the ARQ 531, is in clinical trials. As you can see, the first and second generation, the canonical differences that ibrutinib seems to be the least specific, inhibiting offsite kinases more than the other 2, with the acalabrutinib more specific, and zanubrutinib also between acalabrutinib and ibrutinib. So the first BTK inhibitor was approved by FDA in November of 2013, ibrutinib in relapsed mantle cell lymphoma. This, the first targeted therapy for mantle cell lymphoma, and before the targeted therapy is all chemotherapy. The first ever approved was called bortezomib, and the second one is Revlimid. That's targeted therapy, but really the peak of targeted therapy in mantle cell lymphoma is the approval of ibrutinib in relapsed mantle cell lymphoma. So at that time, the overall response rate was 68%, and as you can see from here, but after that, I quickly did a clinical trial with adding rituximab to ibrutinib in combination in relapse setting. As you can see, with the addition of rituximab to ibrutinib, the response become 88%. The hypothesis behind this addition of rituximab is that BTK inhibitors, especially ibrutinib, can cause the compartment shift phenomena where the drug can drive the cells, mantle cell lymphoma cells, from their home environment, such as bone marrow, lymph node, and spleen, into the peripheral blood circulation, where the mantle cell lymphoma cells are cut off from their home environment. They have no growth signals circulating in the blood. They have not even nutrition. So if by that time you infuse the rituximab and the CD20 antibody right into the circulation, it will crush the half-dead mantle cell cells. So the hypothesis was proven to be effective when you add rituximab to ibrutinib. The relapses mantle cell lymphoma after 3 prior lines, the overall response was 88%. This is really a fantastic therapy. As you can see from the water plot, is very powerful. We use the rituximab ibrutinib in the front line to treat a young patient with the newly diagnosed mantle cell lymphoma. And in order to improve further the overall response rate, in addition to ibrutinib rituximab, we added venetoclax to be a triple combination. As you can see at the front line, in this clinical trial design. The part 1 therapy is ibrutinib venetoclax after 4 cycles. We then add venetoclax. So after the complete remission is achieved, then we move to part 2. Part 2 is risk stratified. So you can see that low-risk patient has no need for chemotherapy. They received 24 months of maintenance therapy with the triple drug, RRV, ibrutinib, rituximab, and venetoclax. The high-risk patient, including high KIC7, over 50%, p53 mutation, and blastoid pleomorphic origin morphology, they would need 4 cycles. With those in between, the moderate risk received 2 cycles. This result was presented in June, actually last month, in the Lugano International Conference for Malignant Lymphoma. You can see among the 50 patients, the risk factors are included. Basically, this patient have standard population of academic population of relapsed mantle cell lymphoma. The overall response rate was investigator evaluated was overall response was 96% and CR was 92%. If you use the investigator initiatives, 88 and 46%, they are both very good responses to efficacy for the chemo-free combination before the chemotherapy. As you can see, if we include the 2 patients who had no measurable disease but had GI and bone marrow disease, and they are in CR, so the whole response rate among the 53 patients by investigator, it is overall response of 100% and CR at 100%. So as you can see, this trial is only about 2 years of follow-up, but so far the field-free survival and progression-free survival are both very good. And there's, of course, if the KIC7 over 30, the patient does not perform as good as when they are less than 30%.
Before you go on, I'm just kind of curious. It's such a fascinating data set you just presented. What's the next step there? Is this going to be brought into phase 3, or what's your plan?
So initially, we were going to plan a multi-center study, phase 3 or phase 2 randomized study. But now the ibrutinib is withdrawal from the market, so the interest is not as high. So I will show you why the U.S. was, FDA withdraw that from the market is based on the SHINE clinical trial. This is the SHINE clinical trial at the primary endpoint results. So as you can see, first of all, SHINE study is a gigantic study including 180 centers in 38 countries around the world, among the best hospitals. And it's a randomized study in the elderly population with newly diagnosed mantle cell lymphoma. As you can see, the whole trial has 523 patients in 2 randomized cohorts. The first arm is the BR for 6 cycles, followed by rituximab maintenance. This is the current standard of therapy. So in addition to this, we also in this arm have ibrutinib 560 PU daily. So basically, this is a standard therapy plus ibrutinib. The second arm is a placebo arm where there's only standard therapy, BR 6 cycles followed rituximab maintenance, but there's no ibrutinib. As you can see, the free survival, which was the primary endpoint of the study, dramatically improved with the 2 curves separated with a very significant p-value of 0.001. So there's a pure 25% reduction risk of progressive disease and death due to the mantle cell lymphoma. So you can see in the experimental arm, the median PFS was 80.6 months. That's like many years, 6.7 years of, okay? However, in the placebo arm, PFS was only 52.9 months, a dramatic difference. However, this did not translate the overall survival. It is this very curve that shows the FDA that the FDA is thinking that, look, you may have a good PFS survival, PFS significance, but you really didn't save anybody because the other people probably is related to the toxicity of the drug. The overall survival overlap on each other, therefore your drug is too toxic, therefore we're going to withdraw your drug from the relapse setting. Okay, so there's so much pressure, and then the companies involved in the drug, they said, if the FDA is going to, if it's going to do a withdrawal, rather than doing a ODAC meeting, we would like to voluntarily withdraw. So the drug is off the market, mainly for relapse setting, but using the frontline setting therapy. So there's a lot of controversy about this. Okay, so the academic world is not in total agreement with the FDA's decision, but the decision is a decision. This is withdrawn from the market. This is affecting a lot of the trials, a lot of therapy of the patient. We have to change and withdraw, and so far, the withdrawal is mainly from the relapse setting, but there's no clear language to see that it is withdrawn from the frontline setting. So a lot of people are still using the frontline setting, but they have to explain to the patient, ibrutinib is toxic, especially on elder populations. It causes atrial fibrillation. How about for younger patients, less than 65 years old? So there's a European gigantic trial, randomized 3 arms called Triangle, because it has 3 arms. As you can see, the first arm is R-CHOP, standard therapy, followed by induction, followed by stem cell transplant. The second arm is, in addition to that, you add ibrutinib to the induction phase and also in the maintenance for 2 years. Okay, the third arm, with the induction therapy, you use ibrutinib for 2 years with the rituximab without any stem cell transplantation. Okay, please remember, arm I and arm A is the main comparison. Okay, as you can see, the patient, this is a gigantic trial with totally 870, and each arm has 200, almost 300 patients. This is the largest randomized trial so far that I know of in mantle cell lymphoma. However, in the failure-free survival, you can see the worst arm is the standard arm. That is the induction therapy, chemo, followed by a stem cell transplant. Whichever arm has the ibrutinib has much better failure-free survival. This includes the arm that with the induction therapy, ibrutinib for 2 years without stem cell transplant. So basically, PFS, you can show that if you put ibrutinib in the induction therapy and you give them 2 years of maintenance, you do not need a stem cell transplant. Okay, so not only that, the overall survival was also significant. The overall survival is the golden standard that all parties in the world would accept, right? This trial caused the overall survival. So the 2 arms with ibrutinib beat the arm without ibrutinib. But so this tells you that the autologous stem cell transplant is not needed. So again, this data is a single trial, and there's also controversial. The people like me, with the lymphoma doctors, we don't like to use stem cell transplant. We think it's too toxic, is bring about secondary malignancies. But the transplanters would not agree. They would think, the trial was only 3 years. You really need a longer follow-up. Maybe the curve will cross. And then the CR rate of the induction therapy was only 30, 50, 40%. This is not needed. This is not good. You don't even need the tough chemotherapies. The chemotherapy was still too tough. We should use chemo-free therapy. So a lot of controversy, but this is the data and I would accept this. I use this to replace transplant. I already started it. So ibrutinib is withdrawn. What about the Acalabrutinib? As you can see, this is the primary publication in Lancet, and the 94% people experienced the reduction. The overall response was 81% with a CR of 40%. But you can see a single oral drug, okay, without any hospital stay, without too much cytopenia, had such a powerful effect after 2 prior lines of therapy in relapsed mantle cell lymphoma. As you can see, the rate, I already told you the response rate, the PFS, overall survival, still comes down with the time, seeing that this targeted therapy, single therapy, is not curable. So how about the combination? This last ASH are presented the AVR, Acalabrutinib, venetoclax, and rituximab. This is a very busy poster, but you can see the three drugs together, the response rate is 100%, with a CR of 90% by PET and 71% by Lugano criteria. So AVR is one of the chemo-free therapies which will replace the chemotherapy, especially in the induction phase. In my opinion, in the future, we no longer need the chemotherapy. We should use chemo-free therapies with the immunotherapies. That's the future for the frontline therapy. As you can see, this is the curve. And how about the zanubrutinib, which is another second generation BTK inhibitor based on the trial? You can see the overall response rate in some of the in relapse setting is 94% in relapsed mantle cell lymphoma, and a complete remission is also very reasonable. So zanubrutinib was also approved by FDA in 2019 for relapsed mantle cell lymphoma. As you can see, the data is also, it's not curable, but its duration, progression, survival is very reasonable. How about the third generation of BTK inhibitors? We have three of them. FDA approved for pirtobrutinib in the green. And you can see the structure available with VRQ here displayed here. So pirtobrutinib is the only reversible non-covalent BTK inhibitor that's been approved by FDA for relapsed mantle cell lymphoma. In this primary presentation presented at ASH, you can see that among the 134 patients, we have a population of standard population of academics in the academic setting, including BTK inhibitors, stem cell transplant, CAR T cell therapy, and different scenarios. But in those patients who is there, basically there's two cohorts. In the one cohort, there's a prior BTK exposure. Okay, as you can see in the on the right side of the top panel, you can see if the patient has been treated with prior covalent BTK inhibitors, the overall response rate is 51%. Okay, the CR rate is 25%. This tells you even the patient has progressed before the BTK inhibitor in the past, a reversible BTK inhibitor appeal of pirtobrutinib with much improved tolerability can still cause a 51% response. But if you look at the waterfall plot, more than 60-70% of people have tumor reduction, but only 50% meet the 50% reduction standard. But how about the patient with this? How come this is so low? I mean, everybody said, you only have 1% relapse lymphoma. But remember, this is a pill. This is after BTK relapse. So in the prior literature, many sites publications on patient with a progress after BTK inhibitor. What's this population's prognosis? Their response rate to non-CAR T cell therapy was only 32%. They only have about less than 1 year to live. In this very sick population, you use a pill, the response rate 51%. That's very, very significant. Okay, the only thing that beat pirtobrutinib in this population is the CAR T cells. Okay, now, so we often use pirtobrutinib as a bridging therapy to bridge over CAR T cells those days. And if you ask the patient what they want to do, they said, give me the pill first. They always prefer the pill. So pirtobrutinib is widely used these days, okay? Now, what if we treat the patient without prior covalent BTK exposure? You can see the overall response rate is 82%. CR rate is 18%, okay? So a lot of people now are using pirtobrutinib ahead of the BTK inhibitors, covalent BTK inhibitors. In fact, there's a trial ongoing, phase 3 trial, head-to-head comparison with the pirtobrutinib versus any covalent BTK of choice. So this trial is ongoing, is very exciting. We should hear about it in a couple of years. So pirtobrutinib, the median duration routine was 18 months, but at the time of presentation, the safety criteria, basically whatever we observed in the covalent BTK inhibitor, the classic side effect, bruising, bleeding, rash, atrial fibrillation, diarrhea, and also infections dramatically improved so far. Of course, this is a 600 some patient, not a trivial population, but the response, look at the bruising, they are all, the atrial fibrillation is only 2%. That's basically the basic rate of any population in this age group. So very good profile, but we have not treated too many patients, and we have not treated too long. So this curve, this will get a little worse with the time, but so far so good is a good start. Okay, we compare with covalent BTK inhibitors. So there's a final population in JCO with the improved longer follow-up shows that the prior BTK, with the prior BTK exposure, the response improved from 51 to 57%, and without the prior BTK exposure, the response stayed at 85%. And the PFS is much looking good with this is only median of 7.3 months, and the overall survival has not been reached after a follow-up of 16 months. So I think with time, this curve will continue to improve longer.